without further ado, delighted to welcome Finn, who you've got sort of 1 foot in UCL, 1 foot in Imperial. Well, you can describe yourself and you can tell us what you're up to. And I think Steve is giving lots of mentoring, and he's hovering at the back if you can't see him. But thanks a lot, Finn. And what we'll do is we'll try and ask all the speakers to keep to 15 minutes, 5 minutes questions, and and then so we'll finish on time. Thank you.
Great, thanks very much. Just let me try and share my screen. That's the first challenge, isn't it? Can everyone hear me okay?
Yep.
Fantastic. And can you all see my screen?
Perfect. Yep.
Lovely. So I'm Finn Catling. I'm a critical care doctor and researcher, and I'm currently a Wellcome PhD fellow at Imperial, where I'm supervised by Tony Gordon, but I'm also supervised by UCLH's own Steve Harris. So today I want to give an overview of how I hope we can use mathematical models to gain insight into patients on the ICU. My focus is on patients with sepsis and how models can provide insight into their cardiovascular status, but I hope to use the same principles in future work to apply and gain understanding in other syndromes we commonly see in the ICU, for example, ARDS or acute kidney injury, for example. There's already a long list of people who have helped shape this work in its current state. I'd particularly like to thank Mervyn Singer for all the advice he gave in the early stages of this work, and what I'm presenting today really rests on a lot of that advice. So on a global scale, sepsis confers a high mortality. 20% of deaths are sepsis related, and zooming in on the UK, more than 50% of patients admitted to the ICU with septic shock go on to die in that hospital admission. And this mortality rate is stubbornly high and stubbornly stable over time, despite great efforts to develop novel treatments, few of which seem to have shown benefit. If we examine the way sepsis is defined, I think we can get a clue as to why that is. Sepsis is defined as life-threatening organ dysfunction caused by a dysregulated host response to infection. And shock is a subset of sepsis in which underlying circulatory and metabolic abnormalities are profound enough to substantially increase mortality. And these definitions encapsulate a heterogeneous patient population in varied clinical circumstances, exposed to a range of pathogens affecting different organ systems and with different patterns of consequent organ dysfunction. And so attempts to protocolize septic shock management often amount to treating this highly heterogeneous group as if they were all the same. And accordingly, calls for personalized medicine in septic shock have grown louder over recent years. However, the desire to personalize is in tension with the need to define a standard of care. We might be comfortable with a personalized treatment plan from a trusted colleague following a detailed holistic patient assessment, but then encoding that treatment plan as that treatment strategy guideline is very tricky indeed. So the real challenge is to deliver personalization and standardization simultaneously. One popular proposed solution to this tension is artificial intelligence. We now have data from hundreds of thousands of ICU patients, many more than any clinician could see in a lifetime. And the argument goes, why not just show the AI system all the data and let it figure out which treatments worked in which patients at which times? The big problem here is that typical AI systems don't have any preconceptions about the world, so that whilst they're great at spotting associations between events, they don't reliably identify causes and effects. I'll give you one example of that. This is a real AI system which was proposed for making personalized prescriptions of IV fluids in sepsis, and trained on a large set of data, tens of thousands of patients. And it ends up recommending, in general, more 5% dextrose and less saline. Of course, we know that 5% glucose is typically used as maintenance therapy in stable patients, and saline is often used to resuscitate unstable patients, at least in these older data. So rather than 5% glucose treatment being life-saving in sepsis, it may simply identify patients who are less unwell, and this doesn't tell us anything about the right treatments to give. So it's this sort of confounding that these AI systems, which are really agnostic to whether they're recommending you videos on YouTube or recommending fluids in a patient with sepsis. They don't have any preconceived knowledge about either of those things. This is the kind of confounding that can often result from that. And this is an easy example of that to spot, but many of these examples are more subtle and could do real harm if they were deployed without a lot of thought. So if we want to use all the data that are available to help us do personalized treatment in sepsis, we need to do it in a way that respects our knowledge of physiology and pathophysiology and how we modify that pathophysiology and physiology with treatment. And mathematical models which describe human physiology have existed for many decades. And here's the famous Guyton model from the 1970s, for example. Each of these little boxes you see is a variable corresponding to the state of part of the patient's body. And if you knew the values of all of these variables for a specific patient, you could predict, for example, what their blood pressure would be over the next few hours, or how they might respond to fluids or to vasopressors. The trouble, of course, is that we don't know the values of all of these variables. Instead, we just have a few things that we can measure routinely in our patients, and we have to go off that. And attempting to use just those few routine measurements in a large, complicated mathematical model like this is kind of analogous to this situation. So in the top line here, we see we have one variable that is unknown, x plus 2 equals 3. Okay, well, x must equal 1. But how about if x plus y equals 3? Well, now we can't pin down what x or what y is. It's the same thing with these little variables in the model. There are so many of them. We have so few data to learn from that we can't work out what the variables might be, and we can't use the values of those variables to inform treatment. So how can we go about working backwards from the few things that we do measure to learning about the clinically important variables that we can't directly observe in our patients? So how can we work out what's going on inside of them from what we can measure on the outside, as it were? There are a few things I try to do in my work to address this. The first is try and use things we routinely measure, but that contain lots of information, much of which we might not routinely be utilizing. This is the reason I'm focusing particularly on the arterial blood pressure waveform, which of course we see in the middle here, and in particular the wave reflection information that this tells us about how waves are reflecting in the arterial tree and what state the arterial tree must be in for those wave reflections to occur in the way they do. Another thing that's essential to do is to simplify the mathematical model we use so that it prioritizes just those variables that are of clinical importance. We can forget what's happening in the big toe, for example. What we're interested in is what's happening in the arterial system, for example. Another thing that's really important to do is to account for sources of noise in the measurements, particularly with reference to the invasive arterial blood pressure waveform we see here. We know this is very subject to noise from perhaps if there's a little blood clot or an air bubble in the arterial catheter, we might see some damping in the trace. And if we don't model that along with modeling what's happening in the body, then we'll draw the wrong conclusions. And another thing it's very important to do is to lean on our prior knowledge about what model variables might be. For example, with a patient's stroke volume, we don't have equal certainty about it being 1,000 mils per heartbeat versus it being 70 mils per heartbeat. Clearly, we'd think it's much more likely to be 70. And we can quantify that mathematically and use it to help us learn from the data that we do have available. How do we go about making a simplification of such a complex model? This model I'm about to present is a little bit of almost a caricature of how we might do this. This is early work from my PhD, just I'm using it to make a point about how simple things might get and then build up to make things more complicated from there. So here we forget about what the heart is doing in terms of the structures within the heart, the valves, the chambers, interacting with one another, and we just model directly what's coming out of the heart. So this is the blood flow directly coming out of the aortic valve, and we're modeling just three simple things about it: how long systole is, what the stroke volume is, and what the contractility of the left ventricle is. And then how simple can we make our model of the arterial system in general? Well, these circuit models are well established in physiological modeling. So here we treat current as analogous to blood volume. we treat voltage as analogous to blood pressure, and then current as analogous, sorry, we treat charge as analogous to blood volume, voltage as analogous to blood pressure, and current as analogous to blood flow. And then we can use resistors like this. For example, this one resistor here corresponds to the resistance of the entire peripheral arterial system. And this capacitor here just tells us how the walls of the arteries expand as blood is ejected from the left ventricle. And this is the source of the famous Finn Catling effect, where we just like storing charge in a capacitor, we store the blood in the elastic distension of, in particular, the large arteries. And then, as I said, it's important to model noise, so we can just use a simple equation to model how this trace here in grey, which might be the true arterial pressure, might get damped, like the orange line here, or underdamped, as we say, where the resonance is these aberrant wave reflections here are which are just a source of error in the catheter, aren't sufficiently damped by the measurement system. So how we might get this underdamped in blue or this overdamped trace in orange. And I mentioned it was important to encode our prior knowledge about what variables might be. And you can do that with these things called probability distributions. That sounds very potentially complex, but you're used to the probability distribution we're using here. This is just the normal distribution. So stroke volume here is modeled as a normal distribution centered around 80 mils per heartbeat, but going down as low as perhaps at slightly under 50 or a bit over 100. And you can do similar things for what you think the systemic vascular resistance would be here, that's R, and what you think the contractility might be. Is it going to be a bit higher than normal or a bit lower than normal? Where I've just standardized 1 to mean what's about normal in this population. And given that prior knowledge, and given a model of how the left ventricle works, how the arterial system works, and how damping in the arterial catheter works, we can then simulate what sorts of measurements we might expect from patients. So here, you can see we have sort of confidence intervals around what the flow coming out of into the systemic circulation out of the left ventricle might be. And similarly, this is the central pressure, but I'll focus on the peripheral blood pressure measured at the radial artery, as we typically do in the ICU. This is, again, confidence intervals around what sort of blood pressures we might expect to see during systole and during diastole here. And the reason we've been able to get these confidence intervals is as a product of our model, but also of those normal distributions we defined over the variables. And then we can compare what we might expect to happen given our model of the cardiovascular system and given our prior knowledge with what we actually observe, the radial arterial pressure waveform we actually observe, which you'll see down here. And suddenly you can see that by this comparison, you can massively reduce the uncertainty over the variables that are over the expected flow that's coming out of the heart, which you can't observe directly, but is connected mechanistically by this model we've defined and is now constrained by this data we observe. I'll just zoom in on these same traces, so I'm not changing anything here, it's just the scale. So you can see here that we've successfully, in blue, modeled the wave reflections you see in the radial artery, and we have a realistic looking central arterial waveform and an aortic inflow, as you might say, a flow out of the left ventricle. And we can compare that with some ground truth from an esophageal Doppler monitor as well, and see that it matches pretty well what we might expect. Similarly, we've compared the simulated waveforms with the data we observe, and we can do the same, and we can also look at how this updates our beliefs over things like the stroke volume or the systemic vascular resistance. So you see in blue, this is what we thought the stroke volume might be, but this is what, given the data, is more likely that the stroke volume is. You can see we've narrowed the standard deviation of this distribution here, and that we're now more certain that the stroke volume is lower. And in fact, that we're more certain that the systemic vascular resistance is higher than we thought previously. And because we have a model of the cardiovascular system, a model of what our prior beliefs are, we've updated those, given some data. We now have everything we need to simulate the effects of treatment. So, for example, this is the stroke volume being augmented in response to a fluid bolus, and the radial arterial pressure rising in response. And similar, this is the systemic vascular resistance being augmented in response to a noradrenaline infusion, and the blood pressure changing in response as well. This is a bit of a teaser from the prototype experiments I'm doing in the early part of my PhD, and there's much that needs to be refined here, and of course lots of this more general physiological model that needs to be adapted to the specific pathophysiology of sepsis. But I hope it's whet your appetite for what's coming next, and I'd be delighted to take any questions. Thanks for your attention.
You've got a few minutes for questions. Anyone on the floor? What's the next? Where do you hope to take it? What's the end product?
I can't hear you for some reason. Why's that?
Can you hear? Can you hear? Can you hear? Ah.
Yeah, can you hear on Teams? So I think it's just Finn.
Perhaps it's my little earpiece that's died here. Let me use a different set of headphones. Could you try speaking again, please? How about now? Just try one more time, please. 1, 2, 3. Perfect. Great. Okay, I'm back.
No. So where do you hope to take it? What's the end product that you want to achieve?
Well, I think there are two applications that I'm most interested in. The first would be, rather than elucidating heterogeneity in sepsis, I think it would be interesting to be able to do early diagnosis of patients with nascent septic shock, because obviously we currently define septic shock as a patient who's adequately fluid resuscitated, has persistent lactatemia, but yet it still remains hypotensive. So this thorny issue of when are they adequately fluid resuscitated is the thing that's probably a bit problematic there, because you sort of end up defining that after the fact. You've given them a load of fluid already, perhaps they're already fluid overloaded, and yet they're still hypotensive. If we had a better marker we could apply systematically to identify patients with nascent septic shock, I think that would be of real clinical utility.
Any questions from either online or the floor?
I actually have a question as well. You say early detection. Do you mean on the wards that you want to detect it? Because the patients there don't have an ARC line. So basically, your patients will be on ICU already. With of sepsis probably.
Yes. I think that's obviously a limitation to this. There are two possible ways to try and get around that. One is non-invasive continuous arterial blood pressure measurement with a finger cuff, for example. The other is looking at the SATS waveform, the PPG, which also has lots of wave reflection information in it, which obviously is often measured in patients who are maybe unwell on the acute medical unit but on a monitor.
Lovely, thank you. Any more? I've got time for one more question. I've got loads, but I'll give other people the opportunity. Let me throw one at you. Another one. A lot of people look at heart rate variability. Do you think there's utility? But people tend to either look at blood pressure waveforms or heart rate. Do you think there's utility in combining them?
I think there would be. I don't plan to look specifically at heart rate variability, or at least I don't have immediate plans to do that. I think it would be important to look at sympathetic drive, and obviously that would affect heart rate. That was the extent to which I was planning on looking at heart rate, but that may change because I'm 1 year into this 3-year PhD, so the last experiment may be a product of what I learned in the earlier experiments.
Let's just ask Steve if he's got anything to add or comment. You might have to shout. Sorry,
No, I don't think so. I mean, I think that.
Can you hear Steve from online?
It's easy to hear him actually.
Yeah, I mean, I think the key bit of what I think is exciting about Finn's work is that there's a lot of people out there doing sort of big data, machine learning, data mining sort of stuff. But I haven't seen many people try to mix what we understand as a biological model of health with data at the same time. And so I think this is really novel and it's exciting. We know a lot about the circulation already. But most approaches discard that and just throw data into a neural network and expect something to come out of it. Whereas actually putting the two together and saying we know how the circulation is supposed to work, now let's see what the data is telling us, and if we merge them together, can we get a better informed position of where we are? I think it's very cool.
So there you are, Finn. Endorsement.
Thanks, Steve.
Thank you, and thank you very much for presenting. Without further ado, I'll ask Muska to take the floor. So, Dr. Miller, who in the middle of her PhD, stopped to have a baby, lovely little babe,
Yes,
the apple of Muska's eye, and she'll talk about iatrogenesis.
So my name's Muska. I'm an anaesthetics and ITU registrar. I'm also a third year PhD student with Prof. Singer and Manu. And essentially my project is what I'm going to discuss, but it's essentially the stuff that we do for patients is some of it which we know is good. If we repeat those good things, can we lead to harm? So that's what it's centered around. I won't bore you with the definition of sepsis because we've already had that, but I'm going to focus more on the pathological processes just to give you a little bit more of a reminder maybe of what happens in it. So essentially sepsis is, we know it's very heterogeneous. We know that essentially lots of different things happen at the same time which end up with organ dysfunction. And what essentially we're interested in are how or when the activation of the multiple processes happen. So the immune system, the metabolic system, all of those, when they're activated, how do they interact and why or how do they lead to organ dysfunction? And in particular, in terms of immune system, when we get the pro-inflammatory responses and the anti-inflammatory responses that happen during sepsis, why do they lead to immunosuppression? And then why is immunosuppression important in terms of mortality and secondary infections? So that's where it's all centered around. Just in case we've forgotten a little bit about immune system, I'm just going to give a mini quick reminder because then I'll talk about stuff that will hopefully make sense. So the immune system has two broad divisions, the innate immune system and the adaptive immune system. The innate immune system essentially involves lots of different other components, but barriers is one of them. Phagocytes, which are cells that consist of things like monocytes, neutrophils, various other cells, they're all main components of it. And then we've got other soluble components like complement, all of which essentially work really fast when there's a pathogen. They work non-specifically to try and activate the adaptive immune system so that the adaptive immune system can then essentially do a much bigger, more coordinated and more specific response and generate memory, which then means that when you have a subsequent encounter with whatever the pathogen was, your response is much more coordinated. So these tend to be what tends to happen. So you get the antigen recognition, you phagocytose it, you produce lots of cytokines, chemokines, which essentially get your cells like dendritic cells and so forth to come forth and pick up tiny bits of fragments of whatever the problem is and present it to the cells of the adaptive immune system, which is the recruitment bit, and the adaptive immune system then becomes activated. So that's very basic. So why is that important in sepsis? Well, in sepsis, we essentially know that there's lots of dysregulation, lots of dysfunction that tends to happen. And these, in my mind, just to make it a little bit simpler, they fall into what happens to cell numbers and what happens to cellular function. So in terms of numbers, we know that there's an increase in apoptosis of both innate cells, but also adaptive cells. So you get an increase in apoptosis, which is programmed cell death. Neutrophils is a bit of an exception in that they have a delayed apoptosis, but that doesn't necessarily mean that that's a good thing, because what you tend to have in the circulation is the less mature cells, so they don't function as well as you would have imagined or hoped. In terms of effective function, as you can see, each cell has its own specific function, and actually what tends to happen is it goes awry. So with monocytes, actually one of the interesting things is HLA-DR, which is a marker of activations of cell, but actually has several other functions as well. It reduces, and this has been shown in septic patients to be associated with cellular anergy, which essentially shows that cells are not working as well as they ought to, or exhaustion, and it's associated with outcome. So that's one of the key things. But actually, if you look at the cells as a whole, you can see that they tend to go more towards anti-inflammatory phenotype rather than pro-inflammatory. And the pro-inflammatory functions, they're not as well as you'd like them. So they don't tend to produce as much cytokines, they don't phagocytose as well. The antigen presentation function of dendrocytes isn't done as well. When you activate the lymphocytes don't work as well as it would have otherwise done. So overall, it's all soup, which is not what you want. And as I said, the main reason why we're interested in this is because of secondary infections and increased mortality. So we don't really know what's unifying, what's driving this dysfunction. And one of the things that might be driving it is mitochondria. Now, I know Prof. Singer is here, and this is kind of his baby. It's not the reason why I like mitochondria per se. Mitochondria is really fascinating. And one of the main reasons is because it is a small intracellular organism that basically happens to exist in virtually all cells. It is the sole provider of 98% of energy in the form of ATP. So its role in all the cells is huge. But it's not just the ATP that it does, actually. It's more things like heat production, biosynthesis of other really important products or substrates like cholesterol or heme or various other things. It regulates or induces the homeostasis of calcium as well as other things. And the generation of ROS is just an example, which is really important in things like cellular signaling. So it's not just related to one cell, but it can coordinate lots of cells. However, if mitochondria becomes dysregulated, which can happen and has been shown, there are lots of things that can go wrong. So one example, as I said, is reactive oxygen species. They can damage cells. They can cause cells to be more susceptible to apoptosis. And not just that, so say we put the function aside, because mitochondria are ancestors of bacteria, to be more precise, alpha proteobacteria, they tend to have components that are similar to bacteria in the first place. So what that means is if you get a component of the bacteria in circulation, that can activate the immune system directly. So some of the things that I'm mentioning are mitochondria have their own DNA. If that DNA gets in the circulation, it will set off the immune system. Cardiolipin is a protein that exists on the membrane. It's another example. But reactive oxygen species, as I said, they don't just cause cellular damage, but they can induce inflammatory responses as well. So why do we actually care about mitochondria in the context of sepsis, even though we understand that its role in a cell is huge? So the main reason is because in sepsis, we have seen that there is essentially organ failure, which is part of the pathophysiology. In organ failure, however, you would expect for there to be less oxygen, but research has demonstrated again and again, actually, there's an abundance of oxygen. It's the utilization of oxygen that's problematic. And as I've already said, mitochondria use approximately 98% of the oxygen to generate ATP. So it's not the delivery of oxygen, it's the utilization. But not just that, when you have cells in organ dysfunction, they actually have a preserved histology, and patients that have recovery after sepsis, they tend to have recovery of their underlying tissue. So this indicates not a structural problem, but more of a metabolic shutdown, which may be driven by mitochondria. So that's why we're interested. And this isn't necessarily, we don't need to go into detail. This is just showing you some of the mechanisms by which mitochondrial dysfunction can happen. So you can have the increase in mitochondrial reactive oxygen species, which can damage cells. You can have reduction in biosynthesis of important substrates that are important for cell function. You can have increased mitophagy, so the mitochondria die or don't function well. Other things like membrane potential. So the membrane is very important to the production of ATP, and in sepsis, it tends to decrease. So these are just some of the mechanisms by which mitochondria can become dysfunctional in sepsis. In addition, mitochondria are extremely important for the actual functioning and survival of immune cells themselves. So when I say that, it's because the ATP that's generated for the cells can be generated via different pathways, and that has an influence not only on survival, but also on function. Not only that, because mitochondria plays such a huge role in biogenesis of lots of different substances, that can then have an effect on cell growth, on immune cells, phagocytosis, respiratory burst, which is part of killing of bacterial cells, and so forth. And as I've already said, mitochondrial reactive oxygen species and components of mitochondria can directly trigger an immune response. So, putting it all together, In terms of what we do for sepsis, as I said, we don't really know the underlying mechanism, but mitochondria is just one interesting component that might explain or maybe unify some of the things that go wrong. What we do day to day when we treat our patients is we do everything supportive. So we give them things like antibiotics. We give them, if it's possible to do source control, you would. And you give them fluids and inotropes if it's severe enough, or you go down the line of ventilation and or sedation because the patient's really unwell, and those are the things that you tend to do. But as you do more, you're causing potentially more harm. And research has demonstrated that the less you do to a patient, yes, it demonstrates that maybe they don't need it, but also actually you're causing more harm. So with that in mind, some of the groups that I've mentioned are antibiotics, catecholamines, and sedatives. They have actually been demonstrated to have they demonstrate immune dysfunction caused by them, but also mitochondrial dysfunction by some of the things that I've mentioned. So the function of immune cells has been directly affected by these in animal studies and in vitro predominantly. And the mitochondria, in terms of ROS production, in terms of complex activity, and some of the mechanisms that I've mentioned can also be affected by these groups of drugs. I've just picked one of each because they're commonly used. They're interesting mechanism of how they work, so I thought I'd have a look at them. So ciprofloxacin, propofol, and noradrenaline are the ones that I've picked. So with that in mind, as I said, we have evidence in terms of their utility. We have evidence that they have an effect on immune cells and mitochondria. But these haven't been studied in septic patients, and they have never been studied together. And obviously, when we study in ICU, we tend to give all of these drugs together. So the question, my hypothesis essentially was, we know that there's immune suppression in sepsis. First of all, can the drugs that we are currently discussing, can they cumulatively cause immune dysfunction? Can that immune dysfunction that already happens in sepsis be replicated or worsened by these medications? And is mitochondria the underlying mechanism for any dysfunction that may happen? So I've been looking at several things, but I'll just go through a little bit of a workflow of what I have done. So far, what I've done is basically taken a bit of blood from colleagues, healthy volunteers, heparinized so it doesn't clot. I've isolated peripheral mononuclear cells, which is essentially all the cells that are not neutrophil or red cells. Main reason is because neutrophils are a pain in the ass to study, honestly. And there are actually lots of different phenotypes, and the phenotypes are difficult to discern and to interpret once you've actually made the study. So I isolated them and got rid of them. Then what I did was I incubated my PBMCs with the various drugs individually, but also together, with and without a septic stimulus. I did this for 6 hours and for 24 hours. And the main reason was because when you have an inflammatory response, I understand in patients that present, it's difficult to do a whole natural history of the study. But essentially, what we did was I chose 6 hours because it's pro-inflammatory to begin with, and immunosuppression or anti-inflammatory tends to predominate at 24 hours. And the things that I studied were mitochondrial membrane potential, reactive oxygen species, phagocytosis, and cytokines. So IL-6 and TNF-alpha, which are pro-inflammatory, and IL-10, which is anti-inflammatory, just to get a range of results. And my ELISA results, as you would expect, in the absence of a septic stimulus, you have no cytokines. In the presence of a septic stimulus, you have an increase in all of them. Because when you have a pro-inflammatory response happening, you have the anti-inflammatory response happening at the same time to try and limit the damage that might be caused by the pro-inflammatory phase. So you get an increase in all of them. When I did the drugs, we've noticed that ciprofloxacin basically suppresses all three at both time points. This is consistent with other literature. Propofol, in my hands, only showed a reduction in IL-10, though there was a trend going down of all of the cytokines. It just wasn't significant. And noradrenaline, in my hand, didn't actually show any changes in cytokines, which conflicts with some of the previous literature. So that's to be discussed. Then I looked at phagocytosis, and essentially what I did was I had unstimulated cells, a means to study and stimulate phagocytosis. So pH RODO is basically analogous with causing phagocytosis, and that's why you see a big change. And cytocolaphin D is something that stops phagocytosis from happening. So then you can see that there is a change. And then I did my various drugs, and as you can see, ciprofloxacin and propofol, they have a significant reduction in phagocytosis, whereas noradrenaline and the mixture of the three drugs didn't show a cumulative effect. This was at 6 hours, and it was replicated at 24 hours as well. So essentially, there's no cumulative effect. Noradrenaline doesn't seem to correlate, and propofol and ciprofloxacin do. Then I did a little bit of mitochondrial studies, and I looked at reactive oxygen species and mitochondrial membrane potential. And I know I'm running out of time, so I'll be quick. Essentially, I couldn't demonstrate any differences between cells that were stimulated and unstimulated with a septic stimulus, and I couldn't see a difference in terms of drugs with and without a septic stimulus, which is unusual because you can definitely see these in septic patients, but not necessarily in vitro. So whether this is real, whether the technique that I'm using, which is flow cytometry, is appropriate or not, is something to be investigated further. So my plan at the moment going forward would be to have a look at other means to see whether what I find through flow cytometry is replicated in other means. So I'll look at glutathione levels, which is basically another way of working out is the reactive oxygen species rising and being swept up by the antioxidant. So this is an antioxidant which you would expect to reduce after reactive oxygen species increase. I'd look at end organ, so end cellular changes. So lipid peroxidation will be a change that happens with reactive oxygen species, and you want to see whether that changes. And oxygen consumption, which is a completely different thing to look at, but might also be another way to see whether the mitochondria are affected or not. Then I'm also thinking what would be interesting is my current techniques are very limited, but pathways can be looked at by gene expression. So that would be also interesting because then it will inform a little bit more about what pathways are involved. Is it just mitochondria? Is there something else that's intriguing? And once that's done, we will then replicate this in septic patients. So thank you for listening. Sorry if I caused confusion, and I hope this is interesting and relevant.
Thank you. Thank you very much indeed.
Thank you.
Could we have the light on just transiently for 3 minutes? We've got 3 minutes for questions. Thanks, Steve. Any questions, please, from the floor, or can we go back to the? Oh, there's Hannah. Francis will get the online people if you stop sharing.
I'm going to not touch it because
I'm not
Can I ask a very basic conceptual model question, which is that is some suppression of these things good or bad? Because if septic shock...
So I don't think we know enough to basically answer that question, and I think the main reason is because we don't know the natural history of sepsis and we don't really know the underlying mechanisms. And I think once we hopefully get to that in the next decade or two, and many decades it takes, then I think we're in a better place to analyse how we're actually affecting that process with the drugs that we're using. But in individuals, you can see that actually immune system, if it's not working, does that then correlate with secondary infections? Does it then lead to mortality? Because that is definitely obvious in patients later on. So if we're demonstrating immunosuppression, I would say it's probably more related to that because it's in my interest too. But if you look at the philosophical question, I don't think we know well enough.
Now, I'm just going to add one liner that, within a couple of doses of antibiotic, most bugs are killed. If not all, yet we give 5 days, a week, 2 weeks. Sedatives, keep going for days and days. And so are we doing additional harm? And as you rightly said, immunosuppression and all the patients not moving, lines, drains. Good and bad. Dave, we've got time for one more question.
But in counter that, most people who die with evidence of infection on board. The infection is not controlled.
Is it infection or is it a process that's not controlled?
No, is it secondary or the primary?
Yeah, no, but pathology suggests you've still got pockets of infection through your lung.
But are they? Sorry,
Because actually, I was going to ask you the same thing. Because how many times do you get a positive culture, or how many times do you actually get a positive source in patients that die of sepsis?
It's not present in the blood. That doesn't mean it's not present in the body.
But that's fair enough. But
Yeah,
but the premise or the evidence that you get in patients that tend to die, you have to go with what you have, and what you have generally isn't invasive procedures. You have blood cultures which are generally negative. I'm not saying that doesn't mean you don't have it, but you don't necessarily have a bug. The evidence of the process is there. And I think that's what we're talking about. What's causing the process? What can we do differently?
A lively discussion on that afterwards. Muska, thank you very, very much indeed. That was lovely. Thank you.
I have a question online. Rashan's question.
Quick again, please. Go on. Sorry, we'll go far away. Sorry, we can't see anyone at the moment. All we can see is Muska's slide. There we are. Thank you.
While Dr. Brealey gets himself ready, we missed Hannah's question, but I wonder whether the sequence we do things is as important as what we do. And has Muska looked at that or planned to look at it? Thanks.
As in which one we give first, second, and third? Is that what you mean? As in antibiotics first thing, then second thing if we need to, IV fluids and inotropes versus.
Yes.
I think it's again very difficult because we don't know the natural history of the disease, unfortunately. And if somebody is needing more, as I said at the beginning, they tend to be sicker, don't they? So I don't think. I mean, we can maybe measure it in vitro, but I don't necessarily think it'll be reflective of what happens in reality. So I don't know if it will be, if it's going to benefit anything, unfortunately.
Thank you. Thank you very much. Thanks, Rashan.
Excellent. That's the mouse to click it on. Okay, well, last of three, but I think I've really enjoyed it. This is better than ESICM or Intensive Care Society. I've learned so much more in the last few, half an hour or so than I do in days going to these expensive conferences. And it also excites me that we can start to put this all together, Muska's stuff, Finn's stuff, and I think over the months we'll hear how interrelated all these things are. Anyway, I'm going to talk about something entirely different. It's not, but it is. I'm going to talk about the clinical research that we do with, and Georgia and Ingrid have joined us at the back, so it's fantastic. We're going to talk about surfactant as a possible treatment for COVID-19 pneumonitis. Now, many of you are groaning, Mervyn particularly, because surely we've done surfactant before. And I've just broken the computer. So if you don't mind getting that, of course, surfactants has been around for ages. We studied it to death back in the 90s and the noughties in ARDS. There were so many trials trying to prove that surfactant was a good thing, but none of them showed any clinical benefit and outcome. Some of them showed some transient oxygenation improvements, some transient improvements in compliance and so on and so forth, but really didn't come down with anything relevant. Are we able to go back on that at all? Previous. So, being a glass half full kind of guy, I go, well, yeah, that's fine, but all the usual reasons apply. ARDS, it's a syndrome. The key is in the name. It's a heterogeneous population. They were involving people with burns, drowning, sepsis, pneumonia. Really? Are they all the same? Well, of course they're not. So don't be ridiculous. How can you compare and contrast? Certainly back in the 90s, we were using injurious levels of ventilation. And the thing with surfactant is it improves your compliance. And if you don't dial down your ventilator, you're going to be starting to damage your patient. Perhaps a little bit of what Muska was suggesting there. Poor fluid management. Again, back in the 90s, we would pour liters into these patients without blinking an eyelid. Edema was seen as a positive and a good thing. And if you took that level of cynicism that Professor Singer has and then applied it, then we wouldn't have steroids and we wouldn't have IL-6 inhibitors for COVID-19. Some of you might say, well, no bad thing there, but it's the truth. So, OBS, surfactant works in neonates. It has revolutionized the way we manage the preterm infants. The neonatologists just chuck it down the endotracheal tube and you get this massive improvement in compliance. And again, their major problem is dialing down the ventilator quick enough to stop barotrauma or volutrauma and stopping pneumothoraces. But why, oh why, apart from a similar-ish chest x-ray, would on earth you consider doing this again in COVID-19? So let's just have a look and ask a couple of questions. What is surfactant? Surface acting agent. What is it? Well, it's essentially a lipid or a lipoprotein, but most of it is composed of this thing called phosphatidylcholine. It contains 4 imaginatively named proteins, A, B, C, D, and it essentially covers the alveolar and your terminal bronchi or respiratory bronchioles in this monolayer that reduces the surface tension and prevents the alveoli collapsing down. So it keeps your alveoli open. It also creates this high surface pressure that prevents the, and I don't know if this is the right word, transudation of fluid into the alveolar space. So it prevents lung edema. Now, protein A and D have antimicrobial properties and can even bind up viruses like influenza. So it would seem like surfactant is quite a useful molecule. Now, surfactant is uniquely produced in these things called type 2 alveolar pneumocytes. And they're essentially found in the alveoli by definition. And it just so happens that SARS-CoV-2 enjoys binding to the ACE2 enzyme or receptor, which is primarily expressed on these type 2 pneumocytes. So it therefore doesn't take a huge leap of guesswork or understanding to suggest that perhaps the SARS-CoV-2 virus is binding to the ACE2 receptor, entering into the type 2 pneumocytes and damaging or destroying them, and therefore impairing your surfactant production. And with the result, you might imagine your lungs become leaky, your alveoli start to collapse, and you're at increased risk of developing a secondary infection. So it's perhaps again not unreasonable to say that surfactant sounds A, important, and B, theoretically could be depleted. What we did learn from the noughties was actually surfactant is, forgive me Muska, reasonably safe thing to do. And we didn't seem to get any major consequences of it. And again, the neonatologists chuck it around and they say there are no side effects. I can't believe it. Anyway, so there's some reasonable theory to this, and therefore not unreasonable to give it another crack.
Is it bovine or
we're using bovine and porcine, and we'll get on to that. So let's go all in. Now, here we would describe ourselves, wouldn't we, Ingrid, George, as a reasonably specialist team that enjoys getting into difficulty with early phase trials. So we've taken two surfactant trials, I'll tell you why in a moment, KOFSA and CuraSurf. And the last thing we are is yet another cog in the recovery trial machine. Nothing wrong with recovery. Well, there is, but that's another lecture. But I think we could do an awful lot better. So let's talk about KOFSA. It's perhaps the most interesting of the two. It's an early mechanistic drug trial and combined with a device in ventilated patients with COVID-19, led by Southampton, but it's a collaboration between the two of us. And the idea is to assess bovine surfactant called Alveofact. It's just a normal surfactant that's made for neonates, and a novel vibrating mesh nebulizer. Like most of these studies, it's dose escalating. It's randomized against standard of care in a 3:2 ratio, and we're looking for 20 patients intubated in the last 24 hours with COVID. Lots of objectives, but this is an early phase study, so it's not about whether you live or die. It's about whether we can see any impact on the mechanism. So we want to see an improvement in oxygenation and an improvement in compliance using something called a ventilation index. Early phase, the other priority is safety and tolerability. So the primary, you can't have a primary, but the top secondary objective was to assess exactly that. And then a bunch of other things that looked like they could be important. Now, unlike recovery, this is a beautifully designed study and starts to ask questions whether surfactant is actually important and whether it is actually involved in COVID-19. So we're going to be looking at things like surfactant lipid composition, its function. We're going to be doing a whole load of immunology stuff, just the sort of thing that Muska would like to get our hands on, looking at synthesis, and again, I never quite understand what oxidative stress is, but we're going to look at that too. And so to do that, we infuse our patients with deuterated methyl D9 choline to start with, and this incorporates itself within your natural surfactant. So it gives us an idea of turnover of surfactant, gives us an idea of half-life, quantity, and so on and so forth. And this is, I think, the real magic to this trial, which is asking the basic science questions before we instantly go on and then give the drug. And the drug is not that interesting the way we give it in many respects, but we've divided the 20 into 4 cohorts. So guess what? 5 patients each, and they will get various amounts of drugs. 0, 8, 24 hours. Now, that seems fine. You can write that sort of stuff up on your drug chart. But for Georgia and Ingrid and Debbie, this is a total nightmare, because that means they have to spend the night with the patient, giving the drug, looking after everything, taking all the samples. So it's an incredibly intense study. So then we thought, well, okay, and we'll look at the results, well, not results, we'll talk about it in a minute, but then we extended the times to make their lives even more miserable for longer. And again, trying to give more over a longer period of time. Each cohort, each one's divided into a cohort to allow a data safety monitoring committee to look at progress as the trial goes on. So perhaps the most interesting bit, and it's probably not doing very well here, is the nebulizer. It's really clever. It has a flow meter here on the ventilator, and is able to measure flow coming out of the ventilator, and as it detects that flow, it turns on, so it starts to nebulize on inspiration. It nebulizes for 80% of inspiration, then turns off, which means any gas now going into your dead space, if your trachea and upper airway, doesn't have any nebulized drug in. So that drug is therefore nebulized and pushed all the way down to where it's meant to be. That's meant to be a video which shows it working on inspiration with this beautiful mist, but we're using UCLH NHS, the Foundation Trust's best IT, and unfortunately, clearly PowerPoint's not quite up to it. So it doesn't really work. But this is an absolutely beautiful nebulizer compared to the usual air-driven stuff that we use. And if you use it in pigs, it absolutely plasters the lung with surfactant. So it looks like it really works. Quite complicated kit. So we've got Georgia here practicing setting it up, because of course, don't forget, these patients are really sick at this point, and we've got to make sure that when we put it together fast and it works when you turn it on, rather than putting it in the wrong way around. So what have we done? Well, we recruited 8 patients. Southampton's similar, so we're not far off. It's really tough. Look, I don't have the results, but it's not a miracle. Okay, they didn't just suddenly get up and walk out the hospital. We've had a few where it seemed to improve compliance, and one dramatically so. But it wears off fairly quickly. In fact, it looks like it's probably got a half-life of about 8 hours, looking at some of our basic science work. And these patients end up being ventilated for weeks, not months, or if not months, and compliance workens over time. So you're left with this feeling like, we could have something here, but are we giving enough? And are we giving it either A, too early, or we're not giving it for long enough? And that's definitely, I think, some of our feelings. Before we just go on to Curacef, that should be absolutely fine. So basic science stuff, we're getting some early results through, and I can't really give you the absolute detail because it hasn't quite been published, but it does look like we've got a surfactant problem, i.e. surfactant levels are significantly lower in COVID-19 patients compared to healthy volunteers, and perhaps one should then. And the lower it is, the more chance you have of dying. So there's something going on there. Whether replacing it makes it better, if not, of course, who knows. Curacef sort of asks the same question using a porcine surfactant. Here they're looking at compliance and PF ratios rather than just being intubated. Daily dosing for 3 days, and here they are looking at a clinical outcome. It's not the most subtle of studies. But because it allows us to recruit up to 48 hours, it allows us to get those patients that fell out of KOFSA. It allows us to give more surfactant. All you do is dissolve it into a big syringe, stick it patient on their side, stick it down the endotracheal tube, roll them onto the other side, and do the same again. It's pretty crude. But that's what they do in neonatology. We've got 5 patients into that. And this is terrifying, taking this big syringe and pushing all that fluid into their lungs, but actually it's really well tolerated. Again, same applies, not a miracle drug, probably too early. Future. Well, an Italian group have gone and taken Curacef and given it an open label as a late rescue. And they report, with all the biases that come with that, some success, but it's very small numbers. Curacef have now gone and opened their trial internationally. We were the first centre, and now it's in the US and Europe. just as causes the COVID numbers plummet. KOFSA are now opening to CPAP and NIV patients. And to really nail it, Rryckaert also think surfactant is a good idea. No evidence suggests it is, but they've taken it on too, which really means everything should be fine and dandy. My personal feelings, and they are just personal, I still think the logic is reasonable. But are we giving enough? Or I think, are we giving it at the right time? I still feel, and I think the girls at the back probably feel, no, we probably should be giving it later. And just to throw it out there, but Steve's left the room, should we be using Bayesian statistics? Because then at least we'd get a positive result, whether it worked or didn't. I'm going to leave it at that. But maybe Rashan can answer that.
Thank you very much. Thank you. Francis, could you put the online people visible? So we'll just come and hopefully see everyone's faces or things. Thank you very much indeed. Right, any questions, anyone? Anna.
Yeah, may I see? You told that the things like surfactant not synthesized in the patients is destroying by viruses the cells, this specific type of the cells. Is it shown by post-mortem examination how solid this data?
Oh, okay. So I think it's pretty clear now that the virus goes in through the ACE2 receptor and helps destroy those cells. Many things destroy type 2 pneumocytes. That was also clear in ARDS. Okay, that was one of the good reasons to give them ARDS. So it's not quite unique to this disease or process.
No. My point is it really is a problem that the cells destroyed and that's why surfactant is low, or for
an impaired mechanism.
Because surfactant has 10% cholesterol. So you did mention it, but so it's basic dependent on cholesterol.
Oh, that's interesting.
Yeah. So how?
Surprised. Okay. So to answer that, we don't know the answer to that. You're absolutely right. We know the cells are destroyed, replaced by type 1 pneumocytes, but we don't know that they're all destroyed and that there is not an additive mechanism that sterile incorporation or some kind of synthetic pathway is not disrupted. So we know we've at least got a destruction cell type, but we don't know whether, the mechanism that incorporates all those things and creates, it's quite complex molecules, whether that's, Also, I mean, there could be other things that make it break down faster, couldn't it? Does the oxidative stress overwhelm it and so on and so forth? I don't know. But I think quite a lot of the sort of basic science work we're doing might start to answer some of it, not all of it, obviously.
Any other questions? Or online, any other questions? Actually, going back to your point then, so timing, dose, and what about type of surfactant?
Yeah, I mean, so to a point, we are limited by surfactant availability. The companies make surfactants for babies this big. And so they only make relatively limited quantities. And then we give it to someone like you. And you need, I don't know, gazillion more. So the supply of surfactant is one problem. So again, when we're thinking about things like Rryckaert, scaling up that production is actually really hard. It's really hard. There are synthetics. So these are what we call the natural ones, and the natural ones tend to work in the kids. So there aren't any synthetic ones that they really use in kids at the moment. They did, but they didn't work. They're trying to make another. I think there's one or two on the trial at the moment, but there's no commercially available synthetic. There were synthetic ones that we used in ARDS. They work just as badly as the natural ones. So we had to get a hold of commercially available stuff. So it's the natural, porcine, bovine. To the neonatologists, they don't really care which one they put down. They use them all interchangeably. They argue a little bit, as everyone argues, about various compositions, but the reality is that the clinical impact of those are the same.
Any final question, anyone? Or online, anyone? Before we... Nish.
So there's multiple strategies that are being used to improve
Can you please shout me? Sorry,
so high peak recruitment maneuvers, nitric oxide, prostaglandins, none of the maneuvers that improve oxygenation in ARDS improve survival in adults. So is that really caused in the pathway to death, if that makes sense? In terms of ultimately improving survival, you might improve the numbers like you do with nitric oxide, but ultimately does it change the outcome of the patient? Or is it just another maneuver that improves numbers?
But yeah, is it just another maneuver that? So again, this is an impossible question that Nish has asked. You know, we're trying to improve oxygenation, but he's saying, is oxygenation really important, or in fact, is it all of Muska's type of mechanism that ends up killing the patients? And it's going to be a mixture of both. Now, to be fair or unfair to the trials, that a lot of the things that we do, from high frequency to ECOR to nitric oxide, we only ever get transient, or we only deliver the intervention transiently, or the intervention only has a transient response. So if you improve your oxygenation for 2 to 3 days in someone who's ventilated for 3 months, it's unlikely to have any major impact. But your point is very well taken. You know, a lot of this, we're just massaging the numbers, whether we make the blood pressure look better with noradrenaline, whether we make the PCT look better with tocilizumab. You know, we're just making the numbers. Are we really impacting on the processes behind this? I really doubt it. Surfactant was never going to cure COVID. It wasn't going to kill the virus and get rid of it. But can it reduce the amount of injury that we cause through our ventilation? And I think that's the main thing. Can we reduce the harm that we do while the patient tries to get themselves better? So a bit like a good thing, but not too much.
On that upbeat note, Dave, thank you very much indeed. Thank you. Like to thank all the 3 speakers for lovely talks. Thank you, Finn online and Dave, and all of you for attending. And for those that are here, there's lots of booze and onion barges and the like. So we'll have the next one in on second Thursday in November. So please do come along. Can I also thank Francis and Riaz for all their wonderful organisational skills. Thank you. Lovely. Have a good evening.